Hey, podcast listeners, guess what? i3 Health is back. If you don't know, Google i3 Health Pharmacy Podcast Network. This organization is bringing us chronic kidney disease information. We're going to be navigating patients through the chronic kidney disease journey by enhancing value-based care. And this is a conversation with Dr. Jeff Sperry. I am so excited about this opportunity. And guess what? Guess who's back? Kira, welcome back to the Pharmacy Podcast Network. We're so glad that you're here.
Hi, Todd. Thanks so much for having us. We're always excited to collaborate with Pharmacy Podcast Network.
All right. The first series has done very well. It's still getting listens. We're going to put in the show notes a link to the original i3 Health series. But I want to jump into today. So, Kira, take us through what is this activity going to be about? Tell us about this upcoming podcast series.
Yeah, absolutely. So we have a podcast series going on right now. It's entitled Slowing Progression of Chronic Kidney Disease Through Value-Based Care. It is co-chaired by Dr. Jeff Sperry, who's one of our guests for today, along with Dr. Justin Buick. And it's a really valuable activity for pharmacists because it not only covers the ongoing and emerging therapies in the field of chronic kidney disease, but also focuses on how to slow progression in order to enhance value-based care. So it's a really valuable topic, and we're excited to delve a little bit deeper into it today.
I love it. I love it. Well, without any further delay, guess what? We have Dr. Jeff Sperry here with us on the i3 Health podcast series. Jeff, it's so good to have you here.
Thank you for having me.
All right. So you are a clinical pharmacist at UC Health Memorial Hospital. You have insights, obviously, into chronic kidney disease. You have this ongoing passion to really dive deeper into treatments and things that are coming out. But before we move forward with this conversation, which I can't wait to get into, let's talk about you. It's putting you on the hot spot. You got to tell our listeners a little bit about your background, but you need to start off with the hardest question, and that is, why did you want to become a pharmacist?
Oh, why did I? That actually is kind of a long story. I originally thought that I wanted to get into more research, take more of a PhD sort of pathway. But then I did research for a little bit, and I just felt that my day-to-day activities were so far removed from being immediately helpful or practical. Of course, bench research is incredibly important, but just my day-to-day activities weren't as fulfilling for me. I wanted something to be a little bit more immediately helpful for people. So that's when I kind of switched paths and started looking into a career in medicine. And so explored a few different areas, but really I think drugs are the most interesting part of medicine. So why not be a drug expert? Why not go to pharmacy school and pursue that path? And I'm very happy that I did. It's been a good fit and a rewarding career for me so far.
That was the right answer, by the way. That was an
perfect
awesome intro. And that's inspiring because we want our pharmacists, our new practitioners, our students to hear these podcasts and understand that with 345 million people in the United States, for example, regardless of the rest of the world, but just in our country, we only have around 305,000 active pharmacists. So just do some math of basic population and the needs of what's going to happen. And it's the best time to be a PharmD right now and a pharmacist, in my opinion. But we want to get into this. So we want you to tell our listeners a little bit about the challenges that your patients have faced with CKD in the current kind of status of what you've seen going on out there.
Yeah, so as you mentioned, I'm a clinical pharmacist specializing in internal medicine. So I work at a large community hospital, and I staff frequently in our renal medicine unit, working with our nephrologists and our patients admitted to the hospital with CKD. So my current clinical practice is entirely on the inpatient acute care side of things. As far as the challenges that we see, I think it's unfortunately there still remain substantial challenges with even just managing some of the comorbidities in contributory chronic disease states, especially, just your bread and butter, hypertension, diabetes, that there still continues to be room for optimization, even on some of the basics. But then there's also a large challenge in coordinating care and ensuring continuity of care for these patients as they move, from our hospital inpatient to maybe a long-term care facility out to the community, all while making sure they have adequate follow-up, especially with their nephrologist or kidney care specialists and outpatient dialysis for some. And also just not to mention adopting some of these newer therapies for delaying the progression of CKD, which we'll discuss later. But at my current practice site, uptake of these new therapies is still lagging to a certain extent, and I think education awareness definitely playing a role. Also, some financial and economic barriers still for patients can be quite significant for some of these newer therapies.
So it's interesting you say that, because we spend a lot of time working with specialty pharmacy and how getting things paid and reimbursed and prior authorizations is a real issue within therapy of itself. And then I think of the education of this. Everyone listening right now has a vested interest in patient care, whether you're a clinical pharmacist. Well, actually, in my opinion, every pharmacist is a clinical pharmacist, but I mean someone who's digging down into research, someone who's working in clinical trials, our community pharmacists, and obviously our geriatric pharmacist that's expanding. So let's talk about that for a second. What is the need for education surrounding chronic kidney disease? And it's kind of a two-part question. What are the educational gaps that you and other pharmacists tend to encounter in your practice and treatment?
I think CKD, it's quite a prevalent disease state. It's just somewhere around ballpark of like 46 million people in the US, and very common comorbidity for our patients that we see in the hospital. And I think it's kind of a common story to many areas of medicine, where as the landscape changes with new guidelines being released, as we have in this example, we actually have some newly updated guidelines from KDIGO, came out just this year in 2024. And some of these newer therapies that have received FDA approval, where there's always that lag time between new recommendations being released and uptake of those recommendations in clinical practice. And so I think education is one of the best ways to help disseminate that knowledge and close that gap amongst clinicians and pharmacists, and especially pharmacists in particular can and should definitely play a role, especially on the medication side of things. And that should definitely be sort of our wheelhouse, something that we can claim and champion.
Yeah, I'm glad you said that, because I'm thinking of the word update and the word news. I mean, something happening that's novel that you really should be tied into or understand or hear about from a credible source of evidence-based practitioners and people that are, passionate about this specific disease state and what their patients are going through, and how you're working with physicians and specialists to extend that. So I think of in consuming information, we're consuming it through reading, we're reading blogs, we're reading the journals. Now we have podcasts. So how does this activity help address some of those educational gaps that we were talking about?
Yeah, so it was a really fun activity that we were able to put together. And I think first off, this activity provides just a really nice overview of general management principles for CKD, just your blood pressure management, lipids, diabetes care, management of complications. So, anemia of CKD, fluid electrolyte, acid base management, bone and mineral disorders. So it's a good review baseline for clinicians and pharmacists. But also in the activity, we try to give particular attention to new and upcoming therapies with an eye toward really slowing the progression of CKD, this is an area where there have been a lot of recent changes and some exciting developments. And so we discuss some of the clinical trials that support the use of these new agents, and we try to really be thoughtful about their place in therapy and what role or what niche they may fill. And then in the second half of the activity, one of our colleagues, Dr. Biot, gives a really nice overview of the managed care side of things, kind of like you were talking about earlier. Exactly. Some of the payer issues, the economic potentially burdens or barriers. And he describes other opportunities for streamlining bundling care and in a way of addressing also some of those continuity of care issues that we talked about earlier as well. So it encompasses a lot of different aspects. So it is a nice, well-rounded activity as well.
Shout out to the listeners right now. If you hear of good information, things that you're reading, things that you're seeing from other providers, other specialists on CKD, I want you to reach out to i3 Health and reach out to their team and get them this information so that we can, as pharmacists and pharmacy professionals and people like me who support you, can get more information out on CKD. So I'm glad you brought that up, Jeff. I appreciate that. I do want to talk about the current direction of CKD. You mentioned before about new treatments, things are coming out, things that you need, you believe our pharmacist providers should be updating themselves on. So I want to go to screening because I see a lot of new screening opportunities, whether it's testing kits or other things happening, obviously, like in community pharmacy and long-term care pharmacy, and definitely specialty. But let's dig down into CKD specifically. How are screening and diagnosis of CKD changing?
Yeah, so kind of as we mentioned earlier, some of the biggest news is that a new set of guidelines released earlier this year in March of the 2024 KDIGO guidelines on CKD evaluation and management, which does talk a lot more about this screening and diagnosis. And this is an update from 2012, so it's been like 12 years since the last full update. In these new guidelines, there's not really any changes in the definition of CKD, although there's some further guidance offered on sort of the initial evaluation of patients with CKD. First, just making sure there's this emphasis on distinguishing CKD from any acute issues, so verifying that it's like a chronic disease state, something present for at least 3 months. They also call attention to using cystatin C as a laboratory value that can be or should be used in addition to SAM-creatinine to estimate GFR, and which you kind of mentioned even like testing in community pharmacies, where they do discuss actually for not necessarily cystatin C, but that there can be a role for especially patients, let's say in rural areas or something like that, where your local community pharmacy can play a really important role in point of care testing that can even be a good way to sort of bring patients into the pathway of care. There's really overall kind of a greater emphasis on earlier screening and diagnosis. Really, the diagnosis is going to depend on evaluating both GFR and albuminuria. And the guidelines in particular will recommend testing for those at risk for CKD. So hypertension, diabetes, especially two of our biggest risk factors. But unfortunately, there's not a lot of evidence as far as regarding the frequency of screening. But again, the emphasis being a greater emphasis on the utility of early detection of CKD. And just given one, that the early stages of CKD are so often asymptomatic and might go unnoticed for quite a while. But two, now that there are a lot of newer therapies available to help slow the progression of CKD, that early detection and initiation of some of these therapies can really significantly alter disease trajectory.
Okay, let's go back to what you said. I forgot to ask you this initially, but you definitely piqued my interest, and I'm sure our listeners want to hear from you. And that is the new therapies. Like, what is happening in chronic kidney disease therapy right now?
So there's been a lot of good, great developments, which is, for quite a while, there really had not been a lot of new therapies in CKD land, but some of the new developments have been very exciting, especially from a pharmacist perspective. So I guess just to highlight a few of them that we're seeing, I mean, most well publicized that everyone's been hearing a lot about recently, but the SGLT2 inhibitors, which have really sort of taken the world of medicine by storm in both, the realm of diabetes, heart failure, and also in CKD. Specifically in CKD, we've seen both empagliflozin and dapagliflozin receive FDA indication for slowing the progression of CKD. These are patients who are already on background therapy with an ACE inhibitor, ARB, patients without diabetes as well. There's also finerenone, so a selective non-steroidal mineralocorticoid receptor antagonist, specifically indicated for diabetic kidney disease, that also has an FDA indication for slowing the progression of of kidney decline. And then in the realm more of anemia in CKD, we have sort of the first oral agent. It's called the Produstat, which is, it's kind of a mouthful, but the hypoxia-inducible factor prolyl hydroxylase inhibitor. But as a potential alternative to our classic erythropoietin stimulating agents.
So, Jeff, one of the things that I'm personally looking forward to, because I'm a technology junkie, is the rise of our digital therapeutics and how maybe blowing into some kind of device, electronic device, to measure either consumption or absorption or something that is in the future. I am for sure that there's going to be a device, but you're in the field, so you are grassroots. What are you looking forward to seeing in the next few years?
In the next few years in the land of CKD, I mean, I think there's still a number of agents, drugs under investigation, and a few new trials that'll be exciting to sort of see. Where we talked about, finerenone, this medication currently approved for diabetic kidney disease, but currently a phase 3 trial underway for finerenone in non-diabetic kidney disease. So it'd be interesting to see if those results hold for those without diabetes. Another hotspot of recent research has really been with another class of agents, the endothelin receptor antagonists. So we do have one agent, it's called sparsentan, that's already approved for IgA nephropathy, which is a rather niche indication, but a few other agents that we may see in the future. Unfortunately, a couple of negative trials that were terminated early due to loss of funding or unfavorable safety signals, specifically seeing risk of fluid overload or heart failure exacerbation. But it's kind of like an interesting approach to address this. There is a new agent under investigation that looks at combining one of these endothelin receptor antagonists. It's called zibotentan, but using that in combination with an SGLT2 inhibitor, in combination with dapagliflozin, this idea that maybe we can mitigate some of that risk of fluid overload and heart failure exacerbation that we've seen with some of the other agents, which is a really interesting approach. As far as I am not aware of any blow into a device type of thing coming down the pipeline for CKD, but just in general, that drug development continues to roll along, which is always good to see, and new innovation for these disease states where like CKD, that's been around for forever, but seeing some newer drugs and newer agents available, or even things like the SGLT2 inhibitors that were originally for diabetes, but this happy finding that they also have been so beneficial for people with heart failure, people with CKD, and that sort of thing. So still continues to be lots of development out there.
Shout out to our physician listeners right now, and that is tapping into the expertise of a pharmacist who is dialed into a very specific condition, disease state, and understanding the treatment. But the reason why I say that, doctors out there and physicians out there, you are the quarterbacks. We are the running backs and the wide receivers for that treatment. Hey, it's football season coming. I had to say that, Jeff, and I'm too excited. But it's the comorbidities. It's the mixing of multiple things together that now the pharmacist who has experience with something very specific, diabetes, hypertension, CKD, it's all mixing together. So what are some of the challenges that for selecting therapies for patients with CKD and conditions that you've mentioned for in creating this comorbid situation?
Oops, I apologize. I think we're getting some weather here, so I've been cutting in and out a little bit. Could you?
Yeah, I'll repeat the question. I'll count you in. And ready? 3, 2, 1. So what are the challenges of selecting therapy for patients with CKD and conditions that we already mentioned? We talked about diabetes, hypertension, and even a bone disorder.
I think, yeah, I guess to kind of look at these different disease states in the realm of diabetes, renal function, I mean, kind of obviously, is something still to keep in mind, where we would early stage CKD, we'd still love to be on metformin, still foundational therapy, although have to be mindful of, holding this or discontinuing during episodes, AKI, acute illness, or anything like that. SGLT2 inhibitors are going to be critical for patients who have CKD and diabetes, and recommended for all in the KDIGO guidelines as long as EGFR is sufficient above 20. And you might see some lower efficacy in terms of glycemic control at the lower ends of the EGFR, but it still seems to retain some of the renal and cardioprotective effects. In the realm of hypertension, still preferring the ACE inhibitors, ARBs, if albuminuria is present, just due to the renal protective effects of these agents. There's not really a preference given to any one particular agent over another, but otherwise, calcium channel blockers still a reasonable choice for controlling blood pressure. Realm of mineral and bone disorders, there's a plethora of options to choose from. So a whole bunch of different phosphate binders, vitamin D analogs, calcimimetics. For some of the newer agents, therapy may still be guided somewhat by insurance coverage. Some particularities maybe among the phosphate binders, limiting or being cognizant of maybe some of your calcium-based agents if calcium is high or calcifications are an issue. Conversely, avoiding some of our calcimimetics, cinacalcet, those types of things if calcium is low. But in general, reserving kind of these vitamin D analogs and calcimimetics for those with more of the severe progressive hyperparathyroidism, whereas everyone else primarily focusing on managing the calcium, phosphorus, vitamin D, metabolic acidosis. So overall, I guess we try to highlight some of these considerations and nuances in the CKD activity as far as selecting patients or correct therapy for patients given their situation and everything. That there can be a lot of different nuances as far as where that patient might sit as far as their stage of CKD and financial concerns, as well as other comorbidities and everything. So again, the activity does a good job, I believe, in trying to help guide people through some of those nuances.
Yeah, the pharmacist is that shepherd of the flock of treatment, and you got to keep them going for multiple reasons. You just discussed therapeutic interchanges. You just discussed insurance barriers. The other barrier that's coming up, and I know this just from talking to so many pharmacists, is that high pill burden situation where you're on multiple medications, 8, 10, 15, depending on what's going on. And now they're forgetting to take their medications, or they let something lapse, or no one's passionate to be sick. These people are going through some stuff. So talk to us about what are some ways that pharmacists can help with adherence for patients suffering with kidney disease.
Pill burden is definitely a big concern. There's actually one study that found that these patients there's like an average of 11 medications a day for patients on dialysis. It was almost half of patients take over 20 medications a day, with a big proportion of that being phosphate binders. So definitely something to address, and a few strategies that pharmacists in particular can play a role will definitely be, first and foremost, just conducting an accurate medication reconciliation and medication review in order to identify any unnecessary medications or medications lacking an indication, as well as any opportunities to maybe consolidate or simplify regimens. Other strategies are largely practical, I guess, in nature, such as the use of pill boxes or patient-friendly med packs to help organize medications. Things like automatic refills, mail delivery, prescription reminders, all these sorts of things, these strategies that can help reduce the burden of managing several different prescriptions or a large number of prescriptions, and helping improve adherence for these patients.
Yeah, I think of the factor of success in medication management and treatment, and then the outcomes, the ultimate outcomes of making either people are being are recovering, or they're managing life with something like CKD, and this is important. So a pharmacist above everything is our safety experts and coaches. You become the chronic kidney disease coach, and that's exciting. So let's talk about setting our patients up for success. How can pharmacists help transition inpatients with CKD and related conditions to outpatient care?
I think some of the most progressive health systems where I've worked, they've all had a very robust system for checking things like insurance coverage, expected copays, any prior authorization requirements, options for various patient assistance programs, or other financial resources for all these new medications that might be prescribed at discharge, and to help figure those things out while the patient is still in the hospital before they get to that point of discharge. Just, yeah, very good research out there that meds don't work well if patients don't take them. At my current institution, this is something that we are definitely have an eye towards developing a good process for this, and a lot of it includes timely communication between myself as the inpatient pharmacist, our provider, and the outpatient pharmacy colleagues. In our system, the outpatient pharmacy has been critical in being able to help us navigate insurance and third-party payer issues, as well as another opportunity I think does include patient education, as you were saying, the role of the coach, being able to talk with patients about their new medications, what they're for, why they're important, how to take them, side effects to keep an eye out for, the standard things, and reconciling those medications at discharge so that patients have that up-to-date med list, adequate refills on everything, have adequate follow-up. So maybe not necessarily the pharmacist's primary responsibility, but having a follow-up appointment already scheduled with their nephrologist is hugely beneficial as well.
All right. In this activity, once again, we're going to have this link in our show notes. So if you are driving, if you're jogging, don't worry. Just go to Pharmacy Podcast Network on the app, on your favorite podcast player. In the show notes, we will have a link to this activity, Slowing the Progression of Chronic Kidney Disease Through Value-Based Care. We're excited. Talk to us about this activity. You covered treatment options for CKD and related conditions, but other aspect was the managed care provider perspective. That is cool. It's all about that collaboration. I have a hashtag #TogetherRx. But talk to us about your interaction with Dr. Bayok.
Yeah, it was great learning from Dr. Bjork and his expertise in managed care, which is, definitely not my area of expertise. I'll say, at least from my end, purely anecdotally, where we do see quite a few barriers as far as insurance coverage, particularly for some of these newer agents, where it seems to be, as the evidence continues to mount in favor of the SGLT2 inhibitors, insurance coverage there seems to be improving, though for some they can still be cost prohibitive. For some of the newer agents we talked about, I mean, I don't see finerenone as often, or I have not seen anyone on daprodustat, but and I do think there's a little bit more of a limited role for daprodustat, maybe for more of those patients who cannot tolerate or have demonstrated a poor response to our standard erythropoietin stimulating agents. But as we've seen in many areas of medicine, prevention is really key. So in this case, slowing the progression of CKD, appropriately managing those comorbidities can go a long way, especially as healthcare expenses really skyrocket once someone gets to the point of end-stage renal disease or requiring dialysis or transplant. And so I think Dr. Bjork did a great job discussing some good insights on the value of care, of bundling care and integrating care. So would encourage you to go listen to his portion of the activity.
Absolutely. Jeff, this has been wonderful in talking with you and setting this up of the importance of our pharmacists to get updated on CKD, the treatments